Cholesterol provides rigidity to cell membranes and is a precursor to bile salts, steroid hormones, and the fat-soluble vitamins A, D, and E. Dietary fat and cholesterol are absorbed in the small intestine and transported to the bloodstream as chylomicrons via the lymphatic vessels. Lipoprotein lipase, embedded in the capillary endothelium, hydrolyzes the triglycerides present in the chylomicrons into fatty acids, glycerol, and a remnant chylomicron. The fatty acids are used for energy or are stored in adipose cells, while the glycerol is recycled to the liver. A hepatocyte binds to the chylomicron remnant, internalizes it, and digests it for repackaging in VLDL particles that are released into the bloodstream. Lipoprotein lipase hydrolyzes triglycerides in the VLDL particle. The resultant remnant VLDL particle, or IDL particle, undergoes further hydrolysis into an LDL particle. Either a hepatocyte or a cell in the peripheral tissue binds to the LDL particle. An LDL particle internalized by a cell in the peripheral tissue is broken down into amino acids, fatty acids, and free cholesterol. HDL picks up free cholesterol from cells in the peripheral tissue and transports it to the liver. Excess LDL enters the intimal layer of the artery endothelium and is oxidized into pro-inflammatory lipids, which attract monocytes. Monocytes cross into the endothelium and differentiate into macrophages. Macrophages consume large amounts of LDL and transform into foam cells. Foam cells release cytokines that encourage atherosclerosis. An atheromatous plaque, or atheroma, is an abnormal accumulation of semi-liquid material in the artery endothelium. It consists of a lipid core surrounded by connective tissue. The connective tissue forms a fibrous cap that prevents bloodstream from coming into contact with the lipid core. An atheromatous plaque roughens the lining of the artery intima and causes turbulent blood flow. The shear stress can rupture the fibrous cap and expose the semi-liquid material to the bloodstream. Because the semi-liquid material contains thromboplastin, it triggers thrombus formation at the site of intimal ulceration. Clinical atherosclerotic cardiovascular disease, or ASCVD, is an umbrella term that consists of the following: acute coronary syndrome, ACS, stable or unstable angina, cerebrovascular accident, or CVA, or transient ischemic attack, TIA, peripheral artery disease, and history of arterial revascularization. For patients at a very high risk of ASCVD, the American Heart Association and the American College of Cardiology recommend adding ezetimibe 10 mg once daily to a statin at the highest tolerated dose to achieve an LDL of less than 70 mg per deciliter before adding a PCSK9 inhibitor. A very high risk of ASCVD is defined as a history of multiple major ASCVD events or one major ASCVD event and multiple high-risk conditions. High-risk conditions include age 65 years or older, hypertension, diabetes mellitus, heart failure, chronic kidney disease, current tobacco use, and a history of arterial revascularization outside the major ASCVD event. ACS is defined as unstable angina or acute myocardial infarction, heart attack. Angina refers to the pain that results from myocardial ischemia. Myocardial ischemia is a condition where the heart muscle does not receive an adequate supply of blood to meet its needs. Myocardial infarction, on the other hand, is a condition where the heart muscle does not receive any supply of blood and consequently dies. Myocardial infarctions can be divided into end-STEMI and STEMI. In an end-STEMI, the ST segment on an electrocardiogram is either normal or depressed. This indicates an infarct in the subendocardium. In a STEMI, the ST segment is elevated. This indicates an infarct from the subendocardium through to the myocardium and epicardium. Arterial revascularization includes placement of stents and bypass grafts. In this picture, we see how coronary angioplasty with stent placement reopens the arterial lumen. In a coronary artery bypass graft, or CABG, a piece of healthy blood vessel is harvested from another part of the body. Common blood vessels include the internal mammary artery in the chest, the radial artery in the forearm, or the saphenous vein in the leg. One end of the healthy blood vessel is attached to the aorta, and the other end is attached below the portion of the coronary artery that is narrowed or blocked. A bypass graft may be preferred over a stent in certain situations, such as in three-vessel disease. Three-vessel disease refers to blockages in all three of the main coronary arteries: the right coronary artery, the left anterior descending artery, and the left circumflex artery. Cerebrovascular disease can be divided into cerebrovascular accident or stroke and transient ischemic attack or mini-stroke. During a cerebrovascular accident, an area of the brain dies due to an arterial blockage. This leads to a permanent loss of certain functions. During a transient ischemic attack, blood flow to an area of the brain is temporarily blocked. This leads to a temporary reduction in certain functions. Peripheral artery disease is atherosclerosis that develops in the arteries of the legs, or less commonly, the arms. Much like in coronary artery disease, one of the treatments for peripheral artery disease is revascularization, such as stent placement or bypass graft. Now we'll switch our attention to measurement and treatment of high cholesterol. Most health systems use the Friedewald equation to calculate LDL. The Friedewald equation calculates LDL by subtracting HDL and VLDL from total cholesterol. VLDL is estimated by dividing triglycerides by 5. It is important that patients be fasting for at least 8 hours prior to presenting to the laboratory for a lipid profile because food intake increases triglycerides. The increased triglycerides yield an artificially low LDL. The Friedewald equation is not used when triglycerides are greater than 400 milligrams per deciliter, and in these circumstances, LDL must be measured directly. This chart shows a breakdown of what cholesterol levels are considered normal in a person without significant medical history. Total cholesterol less than 200, LDL less than 100, triglycerides less than 150, and HDL greater than 50 milligrams per deciliter are generally recommended for health maintenance. Statins lower LDL by inhibiting the enzyme responsible for the synthesis of mevalonate from coenzyme A, which is the rate-limiting step in the synthesis of cholesterol. In a patient with a history of clinical ASCVD, guidelines recommend the use of a high-intensity statin. Statins are considered high-intensity if they lower LDL by more than 50% from baseline. These include atorvastatin, or Lipitor, 40 milligrams and 80 milligrams once daily, and rosuvastatin, Crestor, 20 milligrams and 40 milligrams once daily. Statins may cause myalgia or muscle pain in 2 to 5% of patients. The muscle pain usually presents bilaterally and proximally, such as in the thighs. If a patient experiences myalgia with a high-intensity statin, it is reasonable to discontinue the statin and wait to see whether the symptoms reside. If the symptoms do reside, this increases the likelihood that the statin caused the myalgia. One may then consider restarting statin therapy with the other high-intensity statin. If the myalgia returns, it is recommended to discontinue this statin as well and then retrial statin therapy with pravastatin, Pravachol, pitavastatin, or Livalo, or fluvastatin, Lescol, since these have been shown to have the lowest risk of myalgia. If daily administration of one of these statins causes myalgia, one may consider every other day administration instead. Rhabdomyolysis is a rare condition that affects 0.1% of patients on a statin. It is a medical emergency in which breakdown of muscle tissue leads to acute kidney failure. Statin therapy should never be restarted in a patient with a history of rhabdomyolysis. Guidelines recommend the addition of ezetimibe, Zetia, in patients with a history of clinical ASCVD whose LDL remains greater than 70 milligrams per deciliter despite maximally tolerated statin therapy. Ezetimibe blocks the absorption of cholesterol from the small intestine. Guidelines recommend reserving the addition of a PCSK9 inhibitor for patients with a history of clinical ASCVD whose LDL remains greater than 70 milligrams per deciliter despite maximally tolerated statin plus ezetimibe. The two PCSK9 inhibitors that are commercially available as of February 2020 are alirocumab, Praluent, and evolocumab, Repatha. Pictured here are the Praluent 75 mg and 150 mg pens and the Repatha 140 mg pen. Proprotein convertase subtilisin kexin type 9, or PCSK9, is an enzyme involved in lipoprotein homeostasis. Once LDL binds to the LDL receptor on the cell membrane, the LDL-LDL receptor complex is internalized via an endosome. In the absence of PCSK9, the acidic environment of the endosome causes a conformational change in the LDL receptor, which releases its LDL ligand and is recycled back to the cell membrane where it can remove more LDL from the circulation. In the presence of PCSK9, the LDL receptor does not undergo a conformational change and is instead degraded. PCSK9 inhibitors, like Praluent and Repatha, are monoclonal antibodies that bind to PCSK9 and prevent it from interacting with the LDL receptor. This allows continued recycling of the LDL receptor and thus continued removal of LDL from the circulation. PCSK9 inhibitors are significantly more expensive than statins, and so all health plans require prior authorization. For most cases in the cardiology clinic, the primary diagnosis will be hyperlipidemia, and the secondary diagnosis will be coronary artery disease. The prescription benefit manager essentially wants to know why the prescriber believes that the patient would benefit from an LDL less than 70 milligrams per deciliter and why treatment with a high-intensity statin is not an option for the patient. It is important to compile the following information before starting a prior authorization request for Praluent or Repatha: ASCVD events like STEMI or NSTEMI, revascularization like stents or CABG, a complete list of anti-hyperlipidemics including doses, dates, and reason for discontinuation if applicable. Most plans require that the patient have trialed at least 2 statins, and some plans require that the patient have trialed a statin plus ezetimibe. Find the patient's most recent lipid profile and determine what medication the patient was taking at the time. Most plans require a lipid profile within 3 months of prior authorization request. The following is an example of a patient for whom a PCSK9 inhibitor would be clinically appropriate. Paul is a 65-year-old white male. His past medical history is significant for coronary artery disease, essential hypertension, hyperlipidemia, diabetes mellitus, and chronic kidney disease. His baseline LDL was 160 milligrams per deciliter, and he suffered an ST segment elevated myocardial infarction with an emergent drug-eluting stent placement to the distal right coronary artery in August 2018. At this point, he's considered high risk for clinical ASCVD, and the goal is to have his LDL less than 70 milligrams per deciliter. Paul started atorvastatin 80 milligrams once daily during his hospitalization in August 2018. He developed intolerable myalgia the following month that resolved with discontinuation of atorvastatin. He then started rosuvastatin 20 milligrams once daily in October 2018. He again developed intolerable myalgia the following month, and it resolved with discontinuation of the rosuvastatin. At this point, he's trialed both high-intensity statins, the atorvastatin and the rosuvastatin, and so now the recommendation is to trial a statin at moderate intensity that is less likely to cause myalgia. So consequently, Paul started pravastatin 40 milligrams once daily in December 2018. He's tolerated pravastatin without issue since then. However, his LDL in June 2019 was still high at 115 milligrams per deciliter. And so he added ezetimibe 10 milligrams once daily to the pravastatin in July 2019, and he's tolerated the ezetimibe without issue since then as well. In November 2019, Paul underwent an elective left heart catheterization due to continued episodes of intermittent angina, and the cardiologist found a partial blockage in the proximal right coronary artery, and so placed a drug-eluting stent. During hospitalization for that, they drew a lipid profile that found an LDL of 92 milligrams per deciliter. So now Paul has experienced an ASCVD major clinical event, the ST segment elevated myocardial infarction the previous year, and he's also undergone a revascularization procedure outside of that major ASCVD event. And so he is considered very high risk now, and he's already on the recommended therapy of maximally tolerated statin, the pravastatin 40 milligrams once daily, and he's also on ezetimibe 10 milligrams once daily. So now that he's on the guideline recommended therapy of maximally tolerated statin plus ezetimibe 10 milligrams once day, he is considered very high risk for another ASCVD event, and his LDL is greater than 70 milligrams per deciliter. It is recommended or at least reasonable to add Repatha or Praluent, a PCSK9 inhibitor, in an effort to get that LDL below 70 milligrams per deciliter. So the cardiologist adds Repatha 140 milligrams per milliliter every 2 weeks to the pravastatin and the ezetimibe in December 2019. Since then, Paul has experienced only minor irritation at the injection site, and the LDL calculated in February 2020 was now within goal at 40 milligrams per deciliter. And here I just want to point out that the PCSK9 inhibitor should be added to the maximally tolerated statin and ezetimibe. There's no reason to discontinue the statin if the patient is tolerating it. If you have any questions, don't hesitate to ask. If I can't answer them, I probably can find someone who can. If you've made it all the way to the end of this video, I just want to say thank you very much for watching. I greatly appreciate it.